All right, welcome to your high-yield OB coaching session. Today, we're going to build your clinical playbook for one of the most critical situations you will ever face, a pregnant patient who's bleeding. We're cutting through all the noise to focus on what you absolutely have to know to be safe, to be effective, and to crush your exams.
Okay, let's just dive right in. This is it. The answer to this question is what separates a good nurse from a great one. It's the absolute key to keeping your patients safe, and it's exactly how those high-level exam questions are designed. Your ability to think fast and correctly right here, well, it's everything.
So, before you do anything else, before you even take another step, your brain has to ask this one simple question. Is the bleeding happening early or late in the pregnancy? This is your master sorting tool. The answer to this changes everything. It determines your entire pathway of assessment and intervention. It's how you bring order to the chaos. So if the answer is early bleeding, we're talking first trimester, your mental list should immediately snap to these three suspects. Your job as the nurse is to know the classic signs that tell them apart, because one of these is an immediate ticking time bomb.
Now look at this table. It's more than just a table. It's a rapid assessment tool. But don't just memorize the facts. Look for the patterns. See how the pain for an ectopic is sharp and one-sided? That's your big clue the implantation is in the wrong place, probably the tube. And notice the HCG for a molar pregnancy? It's just astronomically high. That screams abnormal placental growth. This is clinical detective work, you guys.
Let me say this again, because it is a massive safety and exam point. If a patient in early pregnancy comes in with abdominal pain and spotting, you have to assume it could be an ectopic until it is proven otherwise. The risk of that tube rupturing and causing a massive internal hemorrhage is just way too high to ever miss.
And when you see a beta HCG level this high, we're talking over 100,000, yeah, alarm bells should be screaming in your head for a molar pregnancy. This isn't just some random number. It actually explains the other symptoms, like why she might have severe nausea and vomiting from that hormonal surge, or why you might see preeclampsia pop up way before that typical 20-week mark.
So here's the crucial point. Even though the causes are different, your priority nursing actions are universal. You are always assessing for shock. You're looking for that rising heart rate and that falling blood pressure. You're quantifying blood loss. You're checking our RH status for ROGAM. And you are never, ever forgetting that you are caring for a human being who is scared and is potentially losing a pregnancy.
Okay, let's shift gears. We're moving into the second and third trimesters. Now, this is the classic showdown. Every nursing instructor, every exam writer loves to test this, because confusing these two conditions has serious, life-threatening consequences for both mom and baby.
And boom, here it is. This slide shows you the single most important clinical distinction. Just look at that first line for each. Pain. The presence or absence of pain is your number one clue. Think of it this way. Previa is a sneaky, quiet bleed. Abruption, that's a violent, painful event. This one finding is what guides your very next action.
This right here is your memory anchor. Say it out loud with me. Painless, bright red bleeding means previa until proven otherwise. Burn this phrase into your brain. Seriously, it's the rule that will stop you from making a catastrophic mistake.
And here is that mistake. This is an absolute non-negotiable safety rule and a favorite NCLEX trap question. Why? Because if that patient has a placenta previa, where the placenta is covering the cervix, your fingers could literally go right through it, and that would cause an immediate massive hemorrhage. Never, ever, ever do it.
For an abruption, your mindset has to be fast and decisive. The placenta is keeling away from the uterine wall, and that's cutting off the baby's oxygen and blood supply. Every single action on this list is about preparing for an emergency delivery to save 2 lives. This is a race against the clock straight to the operating room.
Okay, so not every threat announces itself with a dramatic bleed, right? Let's talk about a condition where the danger is a quiet, premature opening that can lead to a really devastating second trimester loss if we don't catch it.
The key phrase here, the one that makes this so insidious, is painless dilation. The patient often has no idea it's happening. They might just feel a little pelvic pressure. This is exactly why a history of a prior second trimester loss is a massive red flag, and why ultrasound screening is so vital to catch this.
So you can see the management here is all about being proactive, getting ahead of the problem. A cerclage, it's basically a purse string suture. You're putting it around the cervix to reinforce it and keep it closed. It's a rescue mission, really, to keep that baby safely inside until they reach term.
Okay, let's pull all of this together now. We're going to synthesize everything we've talked about into a high-yield toolkit of meds and universal safety principles that apply across all of these hemorrhagic conditions. Think of this as your cheat sheet.
These 4 medications right here, they're your workhorses in OB emergencies. Knowing why you're giving them and what you need to watch for is absolutely critical. For methotrexate, you're trying to stop the ectopic from growing, but you're still watching like a hawk for rupture. For betamethasone, you're literally buying the baby's lungs precious time to mature. These aren't just meds, they are strategic, life-saving interventions.
Look, I know this is a lot. If you're feeling overwhelmed by all the details, just come back to this slide. These 5 points are the absolute core of safe practice. If you master these, you will protect your patients and you will answer the most critical exam questions correctly. This is your foundation.
And finally, please remember this. Behind every single one of these clinical scenarios is a person, a partner, a family who is terrified and potentially grieving. Your ability to acknowledge their loss, to provide support, and to just be a compassionate human being, that is just as important as any clinical skill we've talked about today.
So let's circle all the way back to our final thought. When your pregnant patient is bleeding, what is the one assessment finding that will most rapidly guide you to your next critical action? We've hit on it a few times now. It's the presence, the location, and the character of their pain. That one piece of data, more than anything else, starts you down the right clinical path every single time. You got this.